to the next bout. So I invite the moderators and chairpersons for the next session, Dr. Ritesh Vekaria, Dr. Senthil, Dr. Nilesh Chandak, Dr. Satyam Udreja, Dr. Pujan Shah, and Dr. Naveen Agrawal. Kindly introduce the speaker and take the meeting forward.
Hello, good evening. Congratulations to CARDIOCON team and Kamal Sharma sir for organizing a wonderful virtual conference. Now we are proceeding to the next debate on a better strategy for coronary bed preparation. Optimal lesion preparation is a prerequisite for successful stent implantation. And we have two experienced speakers, Dr. Mahesh sir and Dr. Bhavesh Roy sir, to go on with this debate. And I move on to Dr. Mahesh sir. Team and Kamal Sharma sir for organizing a wonderful virtual conference. Now we are proceeding to the next debate on
My screen is visible?
Yes, sir.
Thank you, Dr. Kamal, for inviting me. I think I'm the southernmost speaker this evening. And it's, as usual, a fabulously organized meet, and the topics have been selected very carefully. So my topic today is a high-pressure balloon for coronary bed preparation. The bottom line in the success of any angioplasty remains the fact that how well you prepare your bed and how well you deploy your stent. So eventually, what stent you deploy, how many stents you deploy, what is the bifurcation, trifurcation, whatever. If you deploy the stent following the principles of preparing the bed well, post-dilating it well, and making sure the apposition is good, you'll get good results. So what are the reasons why the stents fail? Failure in the stent delivery or expansion, damage to the disc polymer. If you push it through without having prepared the bed well, the coating is going to get damaged. Inadequate diffusion of the drug through extensive calcium. If it persists, the drug doesn't get transferred into the endothelial cells. Impact effectiveness of DES, and increased risk of stent thrombosis or pre-stenosis. So this is the reason why we need to tackle and handle the bed properly before we go in with this. How does it matter? Because more severe the calcium, the worse the outcomes. Horizons AMI and acute coronary calcium studies showed that the death, cardiac death, MI, TLR, and MACE, higher the calcium, proportionate increase in all of these things. So what are the tricks to the trade is, one is imaging. We used to have IVUS at OCT. We may not be able to pass an IVUS or OCT in the initial segment of the imaging. Specifically, in this case scenario, which has been given to me, this is an osteal, short osteal LAD lesion. So the newer cath labs fortunately have the CT scans which can be co-registered with the cath lab images. So if you have one, you're very lucky. Otherwise, just remember that a CT scan helps you to identify the osteal disease very well. Once you have identified the disease, you have there is a algorithm for calcified coronary artery disease, methods to facilitate lesion crossing, and methods to enhance lesion modification, soft fatty fibrocalcific and calcific. So I will just look at the balloon options because that's what I've been asked to speak on. So I'm talking to emphasize on high pressure balloon with uniform expansion. You can have a cutting balloon, or you can have a scoring balloon, which the second part of the speech will be on that. So what is so great about the high pressure balloon? It's got diameter varying from 1.5 to 2.5 up to 4.5, and length varying from 10 to 20. Here the diameters all start from 20 and the length stops at 15. Here the diameters again start from 2 and the length stops at 20. So this is the difference in the very high pressure balloon, cutting balloon, and scoring balloon. Guide catheter is 5 French compatible for a very high pressure balloon. Not very significant because I don't think anybody would go in for a left main bifurcation with a 5 French catheter. So, but anyway, you should know that it is a very small balloon and it can cross easily. There is no proprietary wire required for any of these balloons, but please remember that don't use a hydrophilic wire for a very high pressure balloon because the balloon gets stuck to the wire. And this is very, very important. The balloon crossing profile is only 0.71, which is the smallest as compared to a cutting balloon or an angiosculpt. The nominal pressure is 1013 and it is 608, and you can go up to 3546 kPa. This is almost about 45 atmospheres as compared to about 10 atmospheres or 12 atmospheres for the other balloons. There is side branch protection in both. So the biggest advantage this has that it has got a very low balloon crossing profile and slightly longer than the other balloons. So how do you have an algorithm for a calcified osteal lesion? First, you increase the support. You amplatz the guide or use an amplatzer guide. You can use a guided section. You can use an anchor balloon. You have two types of high pressure balloons that I would like to offer. One is a small high pressure dilatation. This is a 0.85 NC balloon, which can go up to 28 atmospheres. That's phenomenal amount of dilatation. And you have a high pressure OPN balloon, which is starts with 1.5 and go to more than 35 atmospheres. I've gone up to 45. So this is the NIC nano hydro small balloon. It's got a low lesion profile of 0.16 and it's got a hydro coating and it's got a single marker proximally. So advantage is if your marker is inside the lesion, means you have managed to cross the lesion, and you can go up to 28 atmospheres on this particular balloon. Then what are the high pressure uses for preparing the bed, under expanded stent, and even in ISR it can be used. This is the ultra high pressure plaque modification device or OPNC balloon. This again got a very low profile of 0.16. Lesion entry profile is very low. It's got the crossing profile of 0.28. Despite there are two layers in this, and it's got two markers, one at the tip and one at the distal, one at the proximal, even in the 1.5 balloon, making clear that where you stand. And the biggest advantage is that unlike the other balloons, the ratio of increase in size is about 10% when you increase the balloon, even at rated blood pressure, pressure of 35 atmospheres. So it doesn't increase in size. So in addition, what are the biggest advantages? When you use a standard high pressure balloon, you will find that there is up to 20 atmospheres. There is a non-uniform balloon expansion. There could be dog boning, and this dog boning is what causes the vessel wall damage. The edges get dissected, or the healthy segment gets dilated very much, and the area we want to dilate doesn't get dilated. Super high pressure balloon, on the other hand, has a full uniform expansion, eliminates dog boning, and eliminates potential for edge dissections. Hence, it is going to be extremely useful in very tight lesions. So these are the few trials which are shown, and it is shown that in various studies, wherever some of the studies where angiosculpt and rotablator also had not succeeded, OPNC has been successful. So what is the take-home message I would like to say is very simple, that the smallest high pressure balloon is a 0.85 mm NC balloon, which can go up to 23 to 28 atmospheres. That helps you to go in and make a way through to the lesion. The smallest NC balloon is smallest OPN balloon is 1.5 millimeter with two markers. It is 20 millimeters in length. So even that when you have a long balloon being deployed at the ostium, the chances of the balloon slipping in or slipping out is less as compared to a shorter balloon being used. So after you are dilated with a small 0.85 NC balloon, then you can always go ahead and dilate with a longer 1.5 millimeter OPN balloon that will be able to crack the lesion in the same. It can go up to 20 millimeters in length. It's got a full uniform expansion, eliminates dog boning, and eliminates potential edge dissections. So you're able to go in with because of the small size. You're able to dilate because of the high pressure that you can give even for a 0.85 mm NC balloon. And then you can have a 1.5 slightly longer balloon, which will prevent you from sliding in and out. So this is the advantages of using a high pressure balloon in vis-a-vis a cutting or a scoring balloon for a calcified lesion. I rest my case and I hand over to my
Thank you, sir. Thank you for your presentation. I invite Dr. Bhavesh Roy for his presentation. Kindly proceed with your talk.
My slides are visible?
Yes.
Okay, thank you. Good evening, all, and thanks for the inviting. I agree with the Dr. Mahesh, senior respected sir, with the almost all slides which he presented. You very nicely described that how we should go ahead in any of the complex case. First of all, I totally agree with all the slides in the sense that we should prepare the bed, we should not deploy the stent, and once we have deployed the stent without preparing the bed and we have seen the unexpanded stent, then we know that we have invited the big trouble, and then we will be searching that, okay, how to expand this with high pressure balloon and that. Now coming to this specific patient, that he's a male 78-year diabetic hypertension, he's having no stimulation MI, he's having stable hemodynamics, He's having osteal LAD. It's a short lesion, it's a calcified lesion with a dominant LCX and safety with boss. I want to give the safety and best possible result with the no ISR. So how to go ahead? First of all, I agree with it. We should go for the imaging, find out what is the, on the angiography, we may look that it is a calcific lesion and it may turn out to be a much more calcific arc also. And what is the histopathology, whether it is a calcific, fibrocalcific, fibrotic or necrotic plaque. There may be some adventitial calcium which may look like a calcific LAD on the fluoroscopy, but it may not be a superficial or any calcium which will prohibit our ballooning. So whether it is a subintimal calcium arc, I want to see that. If there is a heavy calcium noted in this IVUS, then I will go for the atherectomy device. If there is a mild to moderate calcium, then I will like to give the controlled dilatation with the semi-compliant balloon or with the cutting balloon. Then check the IVUS, check the lumen gain, size it, and complete the stanting. Now, this is the algorithm which probably Sir has also shown in the one of the slide, that approach to calcified coronal lesion. Go for the angiographic calcification, go for the atherectomy device after imaging, and if there is mild to moderate calcium, then you can go for the scoring balloon or the cutting balloon. So far, at present, we have not seen any presence of the ultra high pressure balloon in these of the algorithms as a by default. Now, how the balloon came. These are the balloons since probably more than 20 years in the our practice. These are basically designed to reduce the trauma to the vessel wall. When the sir was showing that semi-compliant balloon, when inflated at high pressure, it causes the wall damage, and that wall damage induces the smooth muscle cell proliferation, and that causes the probably instant stenosis or the late lumen loss. So I want to avoid the trauma to the plaque and elastic recoil, and that's why definitely we should avoid the high pressure damage to this lesion. What is the cutting balloon? Just for the knowledge of our non-cardiologic friends, it is a balloon with the blades over it, and the scoring balloon is having the helical wraparound wires which can cut through the intima, which can cut through the and can expand. So this is how these OCT images look. This is basically instant wrist stenosis image, where the pre-lesion and the pre-dilatation and post-dilatation image, we can see the controlled dissection plaque created. And these are the another images of the right coronary artery of a de novo lesion. So what wrong can happen? During dilatation with the semi-compliant balloon, we may have a dissection. That cutting balloon helps to maintain the T3 flow. We may have an intramural hematoma. The cutting balloon doesn't have that problem because it doesn't create IMH. We may have a dissection of the LMCA. Crossover technique is a good bailout. And as the pressure is just 8 atmosphere, the chances of rupture are very high. The mechanism, you need to understand that mechanism of both stents are, both balloon are different. We need to give a low pressure, slow inflammation at 8 to 10 or maximum 12 atmosphere for the cutting balloon. And if we are going for the ultra high pressure balloon, the pressure has to be around 25, 30, 35. Now, what wrong can occur if the bed is not prepared properly? The stent under expansion, inadequate final lumen, and eccentric expansion of the stent. Eccentricity increased and malopposition and late chances of restenosis can be very high. Limitation of the cutting balloon so far is number one, the crossability. What's this? Crossing profile is definitely larger than the mini balloon or the OP&NC balloon. But remember, this our case is an osteal lesion, and I don't find any crossability issue in this particular case. So it nullifies the disadvantage of this in this case. Now coming to the data, I search for the OP&NC or any other high pressure balloon, and I could not find any randomized trial. Definitely that is not there. Against the cutting balloon, against the scoring balloon, or even in the semi-compliant balloon, we are having a one data which I will come to that slide. These are the data which I will, for the benefit, I will just go little bit fast. We can get the acute lumen, acute cross-sectional area, improved crossability with the cutting balloon. Delivery success rate is good compared to the other balloons. Scoring balloon, then cutting balloon is better than that. The final lumen and acute lumen gain is better. So there are multiple data which says that cutting balloon is better than the semi-compliant balloon, and they have a proven role. Now coming to the, let's see what can happen with the ultra high pressure balloon. That there is a brain fact that OP&NC balloon is safe. We are having 2 layers, balloon will not rupture. This is the actual image of the OP&NC high pressure balloon in the LAD osteal lesion, which has been reported, and it is a log bone in the proximal LAD with the even at 40 atmosphere. This is another image which shows that known deflation of the ultra high pressure balloon in the LAD osteal lesion. This is the shaft rupture. When we go up to high pressure, the balloon layer, plastic layer is made in such a way that it will not rupture, but this shaft is not made of that material. And there are reported 2 or 3 cases of shaft rupture at the connection point, weak point. These are the case, and these are the site of the rupture. This is the right coronary artery with the OP and NC balloon in the mid RCA, and we can see that it is still at 40 atmosphere also. It is not giving away the shaft. So there was this is the OP and NC balloons data. Significant residual stenosis was observed, which could not be resolved even with the at 26 atmosphere and with the even 35 atmosphere. And at 40 atmosphere, ruptured balloon occurred. Rupture occurred at the inflation pressure of 36 atmosphere, and that was just above the rated burst pressure. This was the site of the rupture of the balloon. So this is the CIS Medical is the company which markets this ultra high pressure balloon, and they have reduced the burst pressure from the 35 to 32. And this is the main trial which promotes the high pressure OP and ESAR trial, randomized trial. These are the abstract that it could not show the superiority and in compared to the other preparation. Study limitations, the stent expansion index could not be demonstrated as to be superior one, and conflict of interest, the only one trial and having almost all the investigators having the conflict of interest, and it was an investigator initiated trial, so we do not probably trust. And this is a separate trial, clinical expert, and that also shows, I'm having 20 seconds, the group 2 patients are having 40 atmosphere, more than 40 atmosphere required, and you can see that 47% of the patient required more than 40 atmosphere expansion pressure to dilate these lesions. So if I'm having osteal LAD, crossability is not an issue. I will go for the cutting balloon rather than expanding the 35 atmosphere or 40 atmosphere. But IVUS will guide me further. Thank you.
Thank you for the presentation. Dr. Mahesh sir, any rebuttal comments?
The imaging comes in picture only once you're able to get your catheter across the lesion. So you may not be able to get the catheter across the lesion every time. Secondly, osteal, like there are cases where the shaft is structured. There are cases where the what do you call, the balloon is not deflated. My first case report with Dr. Haridas from Amrita was rupture of a cutting balloon inside the LAD, causing damage to the LAD and dissecting the LAD. So it is not unusual that the cutting balloon also opens out and the blade opens out inappropriately and dissects the LAD, and or they don't get deflated on time. So these complications are common to all the balloons that we across the board use. So what I'm going to say is that the smaller balloon is the ideal one if you don't have space to go through. If you have enough space to image and then go through, then you have other options in life like IVL and the rota. And if you still feel that the cutting balloon is a lower option in my armamentarium, because either way, either if you have made space, go for rota. If you have not made space, then you go for a high pressure balloon. That would be the way I approach. I don't go up to 45. I've gone up to 45 atmospheres only once. The Indian calcium so far has given up by the time I reached 30 atmospheres. They have been very nice to me so far. I agree with Dr. Bhavesh. Exceptions can occur and we can get into trouble, and there is no proper double-blind trial. I wouldn't know why. If it is there, I would like to participate. Thank you. I have nothing against cutting balloon. I use them whenever it is required and whenever it is feasible. I definitely use them. I don't use the blade. I use the ones with the wire wrapped around, because they're a little more safer than the cutting balloon with the blade balloon. Thank you.
Thank you, sir. Chairpersons?
Dr. Mahesh, sir. Just
yeah, sure.
Yeah, Bhavesh.
Although we don't have a data, but this high pressure balloon dilatation do have a vessel trauma over the long term documented by any imaging or anything, vessel trauma? Because
I have first balloon dilatation, which I did at 40 atmospheres, following which I did an OCT in that. I have presented this case. It looks like somebody has thrown a grenade inside the artery. It is shattered. And I was so scared after the OCT. If I lost that wire, I lost that vessel. So you can very happily go up to 40, but post 40, the OCT image of the vessel is literally terrifying. So you've got to be extremely cautious that you don't lose a wire. But only once or twice I've gone around 40. But in 30s, I don't think so much of problem is there. My OCT images, I've done about, say, 15 cases of high pressure balloon with OCT imaging so that I can present them. So most of the times I've got away with murder, but 1-2 times I found that the vessel was really badly shattered.
Yes, thank you.
Chairpersons, Dr. Satyam sir, Dr. Pujan, Dr. Naveen sir, any comments?
Yeah, I want to ask a question. In considering Indian scenario, if we consider reuse of cutting balloon versus reusing of the OPN balloon, which one you people prefer better in terms of reusability? Because OPN is actually not right now available with us. But I know about cutting balloon that it has got a very, very less reusability profile. It's hardly I'm able to balloon of a 2.5 or 3.0 cutting balloon. The reusability is really less. I don't think that second or third time it can be used, the cutting one.
Yes, sir, please.
Yeah, the OPN balloon is no great shakes either. It doesn't get back to its original thing once you've done it. It's very difficult to cross a reused OPN balloon. So that's bad, so please be careful. Cutting balloon may be a little worse than the OPN balloon, but I am very cautious while using a reused OPN balloon. I usually use it for only post dilatation. I don't use it for the initial lesion.
I'd like to tell that we preserve the cutting balloon for the instant restenosis, basically, for the cutting the intimal proliferation, or any take on that, sir?
That is now you see intimal proliferation. You do an imaging, okay, and then you decide what is your balloon of choice. So if the imaging shows plenty of calcium and plenty of this thing, then you should go for IVL if it's feasible. If it does not show and it is just very dense heterogeneous mass, if you have the laser, that is a treatment of choice. Now, if you don't have either of them, then anything is treatment of choice. You can go ahead and go massively into all the things. We can predilate adequately and maybe use a drug-eluting balloon to after you predilated and made the bed, you can use a drug-eluting balloon. So instant ISR is a very safe subset to deal with. The only initial crossing and preparation is a little difficult, but you can do rota, you can do IVL, you can do laser, the works, as long as you get that debarking done properly.
Moderators, Dr. Ritesh, Dr. Senthil, Dr. Nilesh, any comments?
Nothing here. Both speakers, Dr. Mahesh and Dr. Bhavesh, have defended their own points in their own way. Both have been excellent while their talks, and there are limitations of both types of balloons. They have rendered and put their points, and the talks were up to the marks. Both of them have defended well. I have nothing to say here.
Dr. Satyam, any comments?
Very good summarized by both speaker Dr. Mahesh and Dr. Bhavesh Roy. And I want to add ultimately is coronary bed preparation and final luminal gain after stenting. So anything to break the calcium, cracking the calcium is very important. Either you comfortable with CORFLEX or high pressure OP and NC. And if it is severe calcified, then the rota ablation. And imaging is must. So very good presentation by Dr. Bhavesh Roy and Dr. Mahesh.
Dr. Naveen.
Bhavesh, good to have you both. Dr. Mahesh, good to have you again this year as well virtually. We look forward to have you again next year in the real world conference as well. If there are no more questions, I think Dr. Bhavesh did a good justice to defend the osteal lesion. And of course, Dr. Mahesh was upfront with a lot of stuff. The scales were weighed in favor of Dr. Mahesh, and I think Dr. Bhavesh made up for the difference in the level playing field by his counter arguments. And the idea of debate is to promote both utilities and explain both modalities, and just to keep the thing interesting. And neither is, replacement of the other. And there are indications to use either of the case scenarios, which we can use. And if there are no more questions, we can end the session from moderator chairs.
No.
Okay, thank you very much.